So hello and welcome to this video on the management of pancreatitis and its complication. This video is a part of our series on surgical emergencies, and this video is a part 2 on our previous video on which we talked about the diagnosis of acute pancreatitis and how to assess the severity of acute pancreatitis and what imaging studies to use. Now in this video we'll talk about exactly where we left off from the previous video, which is the approach to a patient with acute pancreatitis. Then how do we stabilize someone who's wheeled into our OR or ward? How do we monitor this patient, and which patient do we take to the ICU? And then the nutrition. When do we start the nutrition of a patient with acute pancreatitis? Treating on etiology based, basically what is the etiology of causing this pancreatitis and how do we prevent future pancreatitis in this patient? And then of course the complications of acute pancreatitis that may arise. So let's start with the approach to acute pancreatitis. So in my previous video, I still talked about this, establishing diagnosis. You can go watch this video, how we use the 2x3 criteria, which is basically epigastric pain, raised enzymes, raised pancreatic enzymes, which include the amylase and lipase, and third, supporting imaging studies. I talked about this in detail in my previous video. Now, I talked about identifying severity as well. Now we'll talk about how do we stabilize a patient and how do we evaluate and treat the underlying etiology that has caused this episode of pancreatitis. So how do we stabilize a patient? So we start with, of course, ABCs. Anyone who's walked into our ER, we start with airway breathing circulations, and we get 2 large bore IVs into this patient. We get this patient nil per oral. Why? Because this is the case of acute abdomen. This is somebody that is presenting with acute abdomen, acute abdominal pain. And there are a lot of acute abdominal presentations that might require procedure later on, such as even in this patient with acute pancreatitis, you might have to do, let's say, an ERCP with the case with biliary pancreatitis. So therefore, it's important to have this patient on nil per oral because there might be some sort of procedure that may require this patient to not have eaten anything orally. Then we want to start goal-directed IV fluids. What is goal-directed IV fluids? I'll talk about this in a bit. Then you want to get analgesics following the WHO ladder. So basically this patient has walked in, you want to get them 2 large bore IVs, get them ABCs, and basically get them IV fluids, get them analgesia because there might be in a lot of pain. Patient with acute pancreatitis report a very strong stabbing pain that goes from the front to the back. Therefore you need to get them analgesia. Then antiemetics, PRN, basically if this patient is vomiting, they might have nausea because there is active inflammation in their body. You want to get them antiemetics, and then you want to get general surgery and GI on board for this patient. Now you want to send some laboratory tests. What laboratory test do you want to send for this patient? You want to send amylase and lipase. Remember, lipase is more specific for acute pancreatitis because amylase may be elevated in salivary gland problems as well, because amylase is released by the salivary glands as well. You want to get a CBC. Why do you want to get a CBC? Because WBCs might be elevated. You might have neutrophilia in particular because there is active inflammation. You might have leukocytosis and left shift by neutrophilia. Again, you might have increased hematocrit. Why would you have increased hematocrit? Remember, hematocrit works something like this. For example, if this is a blood vessel, and these are, let's say, the RBCs. These are RBCs. Hematocrit, think of this like this: that whenever we take some blood out, you take some amount of blood cells. Let's say if we take each, then we say this is 2%. Let's say we take all of this water out from this blood vessel. Well, let's say we take all of the water out from this blood vessel. So what will happen is that the RBCs start clumping together. Now when you take an injection of this blood, you'll get a lot of RBCs in this sample. And thus you have doubled the amount of hematocrit. This is like 4%. This is exactly what happens. In acute pancreatitis. You have, in my previous video I talked about this, you have capillary leakage, you have vasodilation, which causes the water to move out, which causes the RBCs to clump together, and this actual clump of RBCs is what you call hematocrit. So raising hematocrit in acute pancreatitis means that your water is third spacing, that your fluid is actually leaking from the blood vessels, which is causing the RBCs to clump together and join again, which is causing the hematocrit to rise. Hematocrit is nothing but basically the RBC component of blood. It is the percentage of RBCs in the blood. If the water leaves, then the percentage of RBCs clump in the blood starts to increase. That is hematocrit, and that is why hematocrit increases. Why do we need a complete blood metabolic panel? Why do we need a complete blood metabolic panel? Why? Because glucose might be increasing, because you might be starting to have some sort of infectious sort of picture in your body. So glucose starts to increase. That does not mean this patient is having, that does not mean acute pancreatitis occurs due to an infection. No, that is an extremely wrong concept. But we want to keep an eye on the glucose because it helps us in monitoring the status of our patient. What else do we look in BMP? We talked about BUN, blood urea nitrogen. What happens with blood urea nitrogen? Blood urea nitrogen is supposed to be excreted by your kidneys. But what is happening is that the amount of blood that is coming into these kidneys, is getting very, very low. Because in acute pancreatitis, fluid is actually leaving the blood vessels. Therefore, the amount of blood that is reaching the kidneys is very, very low. So kidneys try to retain everything that they have. They produce very less or small amount of urine. Therefore, they try to retain even the BUN. What ends up happening is we start retaining BUN. And this BUN can help us in analyzing that is the kidney trying to retain as much water as it can? Is the kidney getting enough blood supply? And this will in turn tell us what is the volume status of this patient, what amount of water is being preserved by the body, and this BUN will tell us. For example, if we have high BUN, that means this pancreatitis is getting severe. Then laboratory tests. What else in the blood metabolic panel do we want? Calcium. Remember, hypercalcemia, I get smash. That H in the smash is for hypercalcemia. One of the causes of acute pancreatitis is calcium. This calcium, and then once you have pancreatitis, you start breaking down, the peripancreatic fat starts breaking down due to the enzymes present in it. Those free fatty acids that get released, for example, if this is pancreas and there is fat around it, whenever you have pancreatitis, this fat starts getting broken down into free fatty acids. Free fatty acids have the ability to bind calcium. This is by a process called saponification. I'm not going to write the whole word because it's a very long word. Free fatty acids bind the calcium. And the level of calcium in your body decreases. Remember, high calcium causes pancreatitis. Pancreatitis cause low calcium. Pancreatitis itself then starts causing low calcium. Why? Because it breaks down the peripancreatic fat. Those free fatty acids that are released in this process bind the calcium and decrease the amount of calcium in your body. And increased calcium is an etiology for acute pancreatitis. It's important for you to remember this because one of the ways we check the severity of acute pancreatitis is by checking the calcium levels. If the calcium levels are getting lower and lower, that means the severity is getting increased. And then you want to get an ultrasound of the abdomen. Remember, every patient will get an ultrasound of the abdomen. Every patient that walks into your ER will get an acute pancreatitis will get an ultrasound abdomen. What else do we need to look at? We need to send some more laboratory tests like the liver function test. Why do we need to send the liver function test? Because the liver enzyme, specifically the ALT, might be elevated. And if it's greater than 150, that's actually very sensitive and specific for biliary pancreatitis. That means that a gallstone actually came out from the gallbladder, moved in here, and got stuck here, which caused the pancreatitis, which caused the autodigestion of the pancreas and thus releasing to infection. Therefore, if you have ALT greater than 150, and this actually gets tested in your exam a lot, they will not give you a lot of cues, but what they will give you is that ALT is greater than 150, and they will tell you what is the cause of pancreatitis here, and you want to pick biliary pancreatitis or pancreatitis due to gallstones. What else? You might have AST to ALT ratio high. So AST might be more elevated than ALT, and what they might be pointing towards alcoholic. They might be pointing towards alcoholic pancreatitis. So you want to keep an eye out for this. Then, of course, if a gallstone is stuck here, you might have increasing levels of bilirubin, you might have increasing level for alkaline phosphatase and GGT. Remember, these alkaline phosphatase and GGT get elevated when there's stuff wrong with the biliary tract itself. Bilirubin gets elevated when there is stuff that is blocking this whole tract, which causes a rise of the bilirubin level. Because remember, bilirubin is excreted through this pathway. It's excreted through this pathway. If you block this pathway, bilirubin will start to rise. And whenever there's something stuck in this pathway, whenever there's something bothering this pathway, you will have increased levels of ALP and GGT, gamma glutamyl transferase. What else do you need to send? You need to send some inflammatory markers, particularly CRP. Procal, you don't need to send Procal right away. Remember, you don't need to send Procal right away. I'll tell you when to send Procal. You don't need to sell IL-6 right away. So you want to keep a question mark on this. For now, you would have to send CRP only. As soon as this patient walks into your ER, you want to send a CRP only, not Procal and IL-6. And I'll tell you when. And you don't want to start this patient on antibiotics. Remember, in acute pancreatitis, we are not using prophylactic antibiotics. In my previous video, I told you about the pathophysiology of acute pancreatitis. Acute pancreatitis happens because pancreas, the enzymes within the pancreas itself get activated and auto-digest the pancreas. It's not due to an infection. I'll talk about when do you consider antibiotics for an acute pancreatitis kind of infection, but for all patients, for most patients, you will not use any sort of prophylactic antibiotics. This is not an infection, it is just an inflammation. So then I talked about goal-directed IV fluids. This is very important. What is goal-directed IV fluids? When a patient with acute pancreatitis is brought into your emergency room, you want to make sure of these two things. Is the patient hemodynamically stable? Meaning, is their heart rate somewhere between 60 to 120? Is their blood pressure, are they maintaining a MAP, which is mean arterial pressure of 65, which is basically 1/3 of the systolic plus 2/3 of the diastolic, plus 2/3 of the diastolic blood pressure. So are they maintaining a MAP of greater than 65? Is their respiratory rate less than 20? And is their urine output greater than 0.5 to 1 milliliter per kg per hour? If they're doing all of these things, if they're maintaining all of these things, that means that they're hemodynamically stable. I explained this for you because when I was a medical student, I used to hear this a lot. Is the patient hemodynamically stable or not? These are the things that at least you want to look at when you classify someone as hemodynamically stable. You want to look at all of their vitals, their respiratory rate, and their urine output, and if they're creating enough urine output or not. Then if the patient is hemodynamically stable, you want to see if they're normovolemic or not, if the volume of blood in their body is enough or not. If they're normovolemic or hypovolemic, do they have enough volume? Remember, volume status is checked on the basis of clinical exam. It's checked on the basis of clinical exam. So what do? You hear their lung sound, see if there are any crackles or not. If there is excess fluid, then you'll hear crackles. If there is no lung sounds, they're normovolemic. Then you want to check skin turgor. Is their skin turgor fine? If they're very, very dehydrated, then the skin pinch time will be actually increased. Skin pinch time will be increased, skin turgor will be decreased. Mucus, you want to check their mucous membranes. You want to open their mouth and check their mucous membranes. Do they look very, very dry? You might have heard this on the ward. The patient is very, very dry. That means their volume status is very, very low. And now in advanced centers, you can do an IVC ultrasound, bedside IVC ultrasound to check. Basically, you go and put this probe directly on the patient's abdomen. You look at the IVC. If the thickness of the IVC is enough, that means you have enough blood. Blood volume. If the thickness of the IVC is decreased, that means your blood volume is decreased and you're hypovolemic. If you're normovolemic, you want to start the patient on aggressive hydration on 1.5 milliliter per kg per hour, Ringer's lactate. Usually this is the preferred due to many sources because there is a risk of normal saline. Normal saline is high in chloride, so there is a risk of causing hyperchloremic metabolic acidosis. Remember, hyperchloremic metabolic acidosis. There's supposedly a risk of hyperchloremic metabolic acidosis. Therefore, you want to use Ringer's lactate at a rate of 1.5 milliliter per kg per hour for these normovolemic patients. And then for hypovolemic patients, you want to give them a bolus of 10 ml per kg and then see if that improves their volume status or not. And this was all for stable patients. What if the patient is unstable? What if the patient is hemodynamically unstable? That means they are very tachycardic, they're not maintaining a good heart rate, their respiratory rate is very, very high, the urine output is not enough. So what do you do for that patient? If the patient is unstable, You want to start them on lactated ringers, basically give them a bolus of 500 to 1000 ml bolus on a 10 to 30 minutes. Over 10 to 30 minutes, you want to give this bolus. And let's assume the patient is stable now. If the patient is stable now, you want to give them everything else that we talked about before. Let's assume if the patient is not stable, you want to repeat this as needed. You want to repeat this as needed. And if the patient still does not improve, that means this patient, this acute pancreatitis patient might be going into shock. Remember, acute pancreatitis can cause hypovolemic shock, which can be very, very deadly. So it's important to stabilize this patient and move this patient to the ICU because they might be going into very, very severe pancreatitis and hypovolemic shock. Move this patient. And we'll talk about the hypovolemic shock management on some other day. Basically, now let us start with monitoring. How do we monitor this patient now that we have admitted, let's say we have stabilized this patient and we have admitted this patient in our ward? How do we monitor them? So for monitoring them, you want to do basically their vitals, their saturation, their saturation of oxygen, their urine output every 1 to 2 hours. Their vitals, saturation, urine output every 1 to 2 hours. And this is not for highly severe pancreatitis. In severe pancreatitis, if the patient is in the ICU, they will have each of these being measured very, very more frequently than 1 to 2 hours. And then you want to give a complete blood count and a blood metabolic panel every 6 to 12 hours. This is not for highly severe pancreatitis. This is for like mild or moderate level of severity of pancreatitis. Now, which patients do you actually admit to the ICU? Which patients do you get to the ICU? Now you have this patient in your ward. What do you want to keep a lookout for? Basically, you want to look if the patient is having any organ dysfunction. And how do you measure this? You measure this with the help of SOFA score. I'm not going to put the whole score here. You can do that yourself. Go on the internet, try to write SOFA score. And if this patient is getting a SOFA score more than 2, that means this patient might be getting into organ dysfunction. You want to consult the relevant experts and think of getting this patient into the ICU. If this patient has very high fluid requirements, meaning they're not maintaining their mean arterial pressure at least more than 65. It's less than 65, you're giving them boluses again and again, this patient is not maintaining MAP, you want to think about getting them to the ICU. If this patient is getting persistent SIRS, what is SIRS? If SIRS greater than 2, which is basically systemic inflammatory response syndrome. Is this patient going into sepsis? Is this patient going into sepsis? If you have a concern that this patient might be going into sepsis, you want to think about getting them into the ICU because they might go into septic shock. So what are the systemic inflammatory response syndrome symptoms? If the temperature is getting lower than 36 or higher than 38, if they're getting a heart rate greater than 90, if they're getting a respiratory rate greater than 20, and if their WBC is either less than 4,000 or greater than 12,000. If you're getting more than 2 of these things, you want to think of getting them to the ICU. Of course, these are not definitive things. You make this clinical decision while you're standing in the ward along with your whole team. Then nutrition. Now there was in most of the acute abdomen presentations that we will study in this series, most of the patients will be kept NPO. And there was this earlier impression as well that you want to keep patients with acute pancreatitis NPO until their acute pancreatitis is resolved. And that actually increased the mortality of patients. What we actually found out is that you want to start nutrition and particularly oral diet as soon as the patient starts to tolerate it. As soon as 24 hours. Basically, you want to start them on oral diet in 24 hours. And if they don't tolerate that, what's the next step? You want to start them on enteral diet. Basically, what is enteral? You start with a tube that goes directly into either their stomach or their jejunum. If it goes directly into NG tube or an NJ tube, you want to start them on enteral diet as soon as possible. And this actually improves their mortality, decreasing the mortality basically. And if its enteral diet is still not tolerated, you want to start thinking about parenteral diet. But basically start the nutrition as soon as possible for people with pancreatitis. Now, how do we treat the etiology? Now, every time that pancreatitis happens, it happens due to those I get smashed causes, which is idiopathic gallstone ethanol trauma, steroids, mumps, autoimmunes, scorpion stings, sulfur drugs, hypercalcemia, hypertriglyceridemia, ERCP, and then some other drugs as well. So every time this is happening, you want to treat the etiology. You want to treat the etiology for this episode of acute pancreatitis. Why? Because you don't want it happening again and again. You don't want this happening again and again. Therefore, it's important to treat the etiology for pancreatitis. I talked about all of these causes. So If you look at these, for idiopathic, we don't know why it happened. We actually don't know why it happened. For gallstones, this is actually biliary pancreatitis. What can you do? You can do an ERCP, and basically for most patients actually which get ultrasound of abdomen, and they found out that they have gallstones, we are basically gonna get a cholecystectomy. You might get a cholecystectomy. If the gallstone is stuck, in the CBD, you might want to get an ERCP, which is endoscopic retrograde cholangiopancreatography. If you have ethanol consumption, basically you want to decrease the ethanol consumption. And then for management of alcoholics, you want to check their levels of magnesiums and potassium when they're in the ward, because alcoholics have usually they have very bad nutrition, so the level of electrolytes in their body is actually very, very deranged. So it's important to keep an eye on these, because you might start getting arrhythmias, particularly with potassium. Then trauma, of course, supportive care. We talked about supportive care, basically getting them fluids. Then steroids, you want to stop the offending drug. You want to stop the steroids. If mumps, you will have to wait it out. Remember, in mumps, you get meningitis infection of the meninges, orchitis, infection of the testes, and then P is pancreatitis. In mumps, you get all three of these infections, so you'll have to wait it out and give this patient supportive care. In autoimmune disease, again, you'll have to get this patient supportive care, but it's good that you call room as well. Why is this thing happening? And this is autoimmune is usually associated with IgG4 related disease, something like Riedel's thyroiditis. Then, of course, if you're getting sulfur drugs, supportive care and stop the sulfur drugs. If you have things like hypercalcemia and hypertriglyceridemia, it's very important to understand this. I'll talk about both of their management, because this gets tested very frequently in your exams, and it's important to know this for the ward as well. For ERCP, remember, ERCP can be used to treat biliary pancreatitis when the stone is stuck, but it can also cause acute pancreatitis, because you're meddling around, you're playing around with this in the pancreatic duct and the CBD. Therefore, you can cause pancreatitis. So what you do is supportive care. And then drugs like NRTIs, protease inhibitors. Importantly, remember the loop and thiazide drugs. What do? You stop the offending drugs. And some other drugs that can cause it, of course, are azathioprine, GLP analogs, and antiepileptics like valproate. There are some of the things. And in most of the things, you stop the offending agent and you start the patient on supportive care. Basically, for hypercalcemia-induced pancreatitis, you want to start again this patient on supportive care. And in management of hypercalcemia itself, the first thing that you do is that you start the patient on supportive fluid, on fluids basically. So that again, that matches with the management of pancreatitis as well, because the mainstay of our management of acute pancreatitis is actually fluid. So it's great, it works pretty well. And then you want to get an ECG, because if you're getting hypercalcemia, if there's stuff wrong with calcium in your body, you want to get an ECG, because you might start having arrhythmias. You want to start this patient on bisphosphonates. Which is the treatment for hypercalcemia. And then you want to get the PTH levels. You want to see why is the amount of calcium in this person's body high? Why is the amount of calcium in this? And then you start them on the algorithm for trying to know why is this patient's calcium high. But we'll talk about that in some other day. Then hypertriglyceridemia, it's important to know the basic treatment for hypertriglyceridemia. If the levels are greater than 500 usually, you want to start them on insulin infusion plus dextrose. But remember, when hypertriglyceridemia is causing pancreatitis, it's very, very high. It's highly likely that the levels are actually higher than even 1,000. That's when we usually get hypertriglyceridemia induced pancreatitis. And then you start, if the patient has very severe pancreatitis or very high levels, meaning greater than 1,000 or greater than 1,200, then you start thinking of plasmapheresis. So now let us talk about the management of complications that may arise in acute pancreatitis. What are those complications? The first one that we are going to talk about today is necrosis inside the pancreas. Well, when you're suspecting necrosis in a patient, what will happen is that you've, let's say, admitted this patient with acute pancreatitis in the ward, but this patient is having persistent fevers. This patient is getting persistently tachycardic, and there is no clinical improvement in this patient. There's no improvement. And a very specific marker is an increase of CRP greater than 150 over 3 days. Basically, if you're getting increasing CRP and even more than 150, that is very specific. That is very specific for necrotizing pancreatitis or necrosis inside the pancreas. And if you're getting high levels of LDH, that means necrosis is happening and the LDH is being released from those pancreatic tissue cells into the blood, therefore necrosis. Similarly, when necrosis happens in the heart, LDH gets released. Similar to that, when necrosis happens anywhere in your body, LDH levels get high in your blood. So it's important that if CRP and LDH levels are increasing, you're getting persistent fever, persistent tachycardia, and the patient is not improving clinically, you might want to start suspecting necrosis in this patient. So you want to get imaging? Well, for imaging, the important thing, remember, you want to get contrast enhanced CT. When every patient that walks into your ER with acute pancreatitis, you want to get an ultrasound abdomen. But if that patient is not improving and if there's diagnostic uncertainty, then at that point, you might want to get a contrast enhanced CT. Particularly for necrosis, what you want to see is gas and bubbles. Gas and bubbles. Basically, what sometimes they might tell you is that there are areas of focal decreased enhancement. That's basically just complicated words, them trying to confuse you in saying that we have seen some gas and bubbles inside the pancreas. You want to transfer this patient to the ICU because this patient is actually going into the category of severe pancreatitis. So this patient needs to be transferred to the ICU. And there they will need aggressive hydration and enteral nutrition, starting nutrition as soon as possible. This patient needs to be hydrated as soon as possible, and enteral nutrition. Remember, for most of the management of pancreatitis is just going to be supportive care with aggressive hydration and nutrition as soon as possible. What other complication? Now you're suspecting, now you have the same patient and the patient is still not improving. Then, and the same clinical features, you're getting persistent tachycardia, you're getting persistent fevers, you're seeing no clinical improvement, and you're also seeing some increased level, basically on contrast enhanced CT, it's going to be the same thing, gas and bubbles, but now you're seeing those increased inflammatory markers that we talked about, those IL-6 and procal. IL-6 and procal, and now you're suspecting maybe a bacterial infection. Now suspecting a bacterial infection that might be happening. This is the point where you might start considering very broad spectrum antibiotics. This is the point where you actually start giving antibiotics. No other point in this journey did I tell you to start antibiotics. This is the only point when you start suspecting that this patient is actually not improving. We are seeing necrosis on contrast enhanced CT. We are aggressively hydrating. We are trying to start nutrition, but this patient is not improving. At this point, you want to get these inflammatory markers like IL-6 and procal and start suspecting that this patient might actually be getting infected necrosis and this patient might require antibiotics. What is the treatment? You want to start them on supportive care, which is basically just hydration as much as possible, and broad spectrum antibiotics like meropenem 1 gram IV per every 8 hours for 2 to 4 weeks. For 2 to 4 weeks, this patient will require at least 3 doses of meropenem 1 gram every day for 2 to 4 weeks to resolve infected necrosis. What else do you want to do? You want to drain. If, for example, if on broad spectrum antibiotics, this thing does not improve, you feel like this thing is not improving on broad spectrum. Remember, if things are not improving, if not improve, then you want to start for percutaneous drainage, CT guided drainage, maybe in the first 2 weeks when you think things are actually too severe to wait more than 2 weeks. And you might even have to go for operative necrosectomy. That is an operation that is performed to remove the area of necrosis in the next 2 to 4 weeks based on analysis by basically your GI and interventional radiologists. So if the patient is not improving with infected necrosis by just broad spectrum antibiotics, you want to consider percutaneous drainage and operative necrosectomy. What are the late complications? What are the late complications that may arise? So what I want you to understand is the difference between pancreatic pseudocyst and walled-off necrosis. Both are encapsulated by layer of well-encapsulated by layer of granulation tissue. Remember, it's a pseudocyst. It's not an actual cyst. An actual cyst is encapsulated by epithelial tissue. But pseudocyst is not encapsulated by epithelial tissue. It is encapsulated by granulation tissue. And the same goes for walled-off necrosis as well. But they are both encapsulated. These are the similarities between the two. Both are late complications. Both arise greater than 4 weeks after the episode of acute or chronic pancreatitis. This walled-off necrosis usually arises after an infection of necrotizing pancreatitis, and pseudocyst can just arise after an episode of acute inflammation. Well, the difference between the two is that the walled-off necrosis will contain both solid and fluid components. Why? Because basically what is happening is liquefactive necrosis. What it is happening is, for example, if this is the pancreas, some of this pancreas is getting liquefied by necrosis. You're getting this sort of a mixture. You're getting this sort of a mixture between fluid and solid. So if you look at this in contrast enhanced CT, you will tell that there is sort of a mixture of solid and liquid in this walled-off necrosis. And exactly that is the difference between a pseudocyst and a walled-off necrosis. A pseudocyst will contain only fluid. Fluid only will be something like this. If this is the pancreas, and you will see a cyst here, and that is filled with fluid only. What else is the difference? Well, pseudocyst is often asymptomatic, meaning the patient will not, basically you'll just get a contrast enhanced CT and you'll start seeing that pseudocyst inside the patient. And a patient with walled-off necrosis can also be asymptomatic, but a lot of the times, for the purposes of your questions, and whenever you see on ward, the patient might report fever, nausea, and vomiting. But of course, they can also be asymptomatic. It's not just that the pseudocyst will be asymptomatic. And then in both of these, you might have pressure effects. What are pressure effects? Basically, there is this huge ball that is now lying inside the pancreas. There is this huge ball of tissue that is now lying inside the pancreas. And what might that cause? What might that cause? Well, that might start having pressure on the gastric outlet. And what will happen? For example, if you just look at this, there are a lot of structure that lie close to it. For example, this is the stomach. This is the stomach, and you might block this a huge cyst might actually block this part, and then you might have a gastric outlet obstruction. For example, what else is in this place? You have the CBD that is coming down in this place. You have the CBD that is coming down in this place, and therefore you might have an obstruction of the CBD itself. Therefore, you might start getting jaundice. So these are the pressure effects that are present due to its location in this place. If, for example, you block the gastric outlet, the patient may also report that, I don't want to eat. They suddenly start reporting decreased appetite or increased satiety. That might be the main presenting symptom in both of these, that pressure effect that the patient does not feel as much appetite because the outlet to their stomach is being blocked by this huge pseudocyst or walled-off necrosis. So, as I told you, walled-off necrosis will contain both solid and fluid, and the pseudocyst will only be homogeneous. Basically, it will just be a ball of fluid on the pancreas. It will just be a ball of fluid, homogeneous. Now, for pseudocyst, you might have increased amylase levels, and that might be the main presenting thing, that you're getting this patient who starts suddenly reporting satiety, they start reporting decreased appetite, and you check their blood amylase levels, and their blood amylase levels are high, but they don't report any other symptoms of acute pancreatitis like pain or anything else. And you check their CT, and suddenly you see that huge cyst. That fluid-rich cyst is actually, that fluid is very rich in amylase, so you start having that elevated amylase levels. For walled-off necrosis, you will have high leukocytes, high CRP basically, and then fever-like symptoms because there is necrosis happening that is walled off, this abscess-like. Remember, walled-off necrosis was previously called pancreatic abscess. So elevated levels of CRP, elevated level of leukocytes are particular for walled-off necrosis. And how do you treat them both? Well, if walled-off necrosis or WON is symptomatic, you drain it. You do it, preferably you do it endoscopically. But if that is not feasible, you do it CT-guided percutaneously with the help of interventional radiologist. For a pseudocyst, when do you drain it? If it's greater than 6 weeks old, you consider draining it. Basically, if this patient is symptomatic, then this is a decision between the doctor and the patient if they want to consider draining it. If this cyst is getting greater than 6 weeks old, you want to start consider draining it. Or if it's greater than 6 centimeters, what's the risk? Well, what happens is that these cysts sometimes contain blood vessel pseudoaneurysms. They contain blood vessel pseudoaneurysm, and they carry a high risk for hemorrhaging into this pseudocyst, and then the pseudocyst might burst, and then you have hemorrhage inside your body. Therefore, if the cyst is getting very large, or if it's present for a long time, then you might want to start thinking that there might be pseudoaneurysms being present in this pseudocyst. So let's just drain it. Now, before I conclude this session, I want you to understand how a CT of a pseudocyst and a walled-off necrosis actually looks. So this is what well, take a guess. This is a pseudocyst because this is very homogeneous in the way it looks. All of it is very, very gray and very similar in the way it looks. This is actually a pseudocyst. This right here is the pancreas, which is covered by these two very, very huge pseudocysts. There is a reason I put very huge and obvious things. This is a pseudocyst, and this is present on both sides of this pancreas, and it's very homogeneous, it's gray, it's one color, it's fluid filled, and this person might have high amylase. This person might have high amylase because this fluid is actually high in amylase. Again, this is an axial CT. This is the patient's left side, this is the patient's right side. This right here, the part that you're seeing here, is the liver, this is the gallbladder, these are the kidneys, and this is the vertebra, and this slight calcification that you see right here is actually an aorta, in the aorta, and this is an incidental finding. So let us move forward. Now right here I have two CTs for you to review. This right here, what sort of a section is this? Yes, it's an axial section. For example, the patient is lying like this, you're standing on the patient's foot end, and somebody has cut through, given you a cross section of this patient. This right here is definitely the left side, this right here is the right side. On the right side you can see this huge liver, this right here is the spleen, this right here is the spleen. So this is the aorta, and this aorta is actually very, very lit up, so you can see this is contrast enhanced. This is the vertebra, these are the ribs, and this right here, this structure right here is our pancreas. But this is not very, for right off the bat you can see in the pseudocyst it was very homogeneous, all of it was only one color, but this is a very, very mixed sort of picture, It's slightly more dense here, it's less dense here, and there you see the pancreas here. So this enhancement is very, very mixed. Right off the bat in this axial section you can tell that this is actually walled off, because there is a wall that you can say this is actually walled off necrosis. And this, what sort of a section is this? I will try to, this is a coronal section. This is a coronal section. So if a person is standing like this, you have cut through the person like this. This is the left side, this is the right side, this is the patient's liver, and this right here, it's the same person's coronal section, and this right here is walled off necrosis. This is the wall, and here right say you see this heterogeneous mixture of solid and liquid. Now I'll talk about something for the sake of completeness, very optional, not a super high yield thing to know, but for some reason examiners love this, which is sphincter of oddi dysfunction. Sphincter of oddi dysfunction is basically if this is the pancreas, this is the CBD, this is the pancreas, and this pancreatic duct opens, where it opens into the duodenum, there is this muscle called the sphincter of oddi, which is basically a muscle. And if you have dysfunctional contraction, and relaxation, you might precipitate episodes of right upper quadrant pain, and opioids can worsen this pain. This again is an MCQ or a question that examiners love for some reason, and then you might get episodes of recurrent acute pancreatitis, and this is a diagnosis of exclusion. You can't just directly go, if someone is getting recurrent acute pancreatitis, you can't just directly say that maybe this function is sphincter of oddi dysfunction. You want to make sure that there's nothing else wrong in the I get smashed causes that we talked. So this is the diagnosis of exclusion. And then how do you diagnose it? You diagnose it on the basis of sphincter of oddi manometry. And if you find out that this patient has dysfunctional contraction and relaxation of the sphincter of oddi, you want to do a sphincterotomy with ERCP, basically endoscopic retrograde cholangiopancreatography. You want to go in and do a sphincterotomy. This is just an optional thing. I've added it here for the sake of completeness. Not a super high yield thing for the wards, but something you should remember for your exams. So now we can go towards the takeaway from this lecture. What's the takeaway from this lecture? So first of all, I want you to understand the approach towards acute pancreatitis, which will be diagnosis based on the 2 out of 3 things that we talked about. You want to stabilize, and you want to assess the severity using those BICEP score, CT severity index, or Ranson score. And then you want to treat the etiology. How do you stabilize? You start with the ABCs, you get IVs, and then you get that goal-directed IV fluid based on if the patient is stable or unstable. And then if the patient is stable, if the patient is normovolemic or hypovolemic, and then you want to get some fluid in. And then you want to get the patient on NPO, you want to get the patient nil per oral because this patient might require some sort of procedure. You want to get some analgesia because this patient will be in a lot of pain. You want to get antiemetics if this patient is vomiting. And basically also you want to decompress the stomach if this patient is recurrently vomiting. You can decompress by putting an NG tube in, and you should get an ultrasound abdomen in every patient with acute pancreatitis. You want to send lab tests which include WBC. Why? Because you want to look at the complete blood count. You want to look at the WBCs or leukocytosis if there's active inflammation. You want to send a complete blood metabolic panel because you want to look at calcium and all of the electrolytes that we talked about. You want to also look at glucose. You want to look at LDH levels because if LDH levels are high, as I told you, there is a high risk that the patient might actually be going into necrosis. Then CRP is also very good for basically measuring if the patient might go into necrosis or not because you keep following CRP up. And then you want to take a look at the LFTs because if the ALT is higher than 50, you're suspecting biliary pancreatitis. If the AST to ALT ratio is skewed, then you're suspecting alcoholic pancreatitis. Then goal-directed IV therapy. If the patient is stable, you want a normovolemic, you want to start them at this rate. And if the patient is hypovolemic, you want to get them a bolus of 500 to 1000. And if the patient is unstable, what do you do for a patient is if they're unstable, you want to start them on a bolus of 1000 ml fluid stat. You want to repeat as required and then go into hypovolemic shock management if that patient does not maintain their MAP greater than 65. Maintain their MAP greater than 65, you want to go into the management of hypovolemic shock. How do you want to monitor? You want to do vitals, saturation, urine output, CBC and BMP of the patient in your ward. Keep doing the vitals every 1 to 2 hours, CBC and BMP for a normal patient around basically 6 hours. And then for who do you want to get for ICU admission? Somebody who has a high SOFA score, a MAP less than 65, they're not maintaining their MAP, they have a very high fluid requirement, and they have persistent SIRS greater than 2, you want to get this patient into the ICU. What are the possible causes that you want to evaluate? For gallstones, ERP, cholecystectomy is your mainstay of management. Ethanol, stop drinking so much, and also manage the alcohol-induced pancreatitis. Manage their electrolytes levels. You want to stabilize them. You want to get some thiamine for them. Then trauma, you want to do supportive care. Steroids, stop the steroids. Mumps is just supportive care. Autoimmune, supportive care and call room. Then sulfur drugs, stop the offending drugs. Hypercalcemia and triglyceridemia, we talked about their management. Hypercalcemia, you want to get them on bisphosphonates and a lot of fluid. Triglyceridemia, you want to start them on insulin and glucose, but if their levels are very, very high, you want to consider plasmapheresis. ERCP, if it's ERCP induced, it's just going to be supportive care. If it's drugs induced, you want to stop the offending agent and start them on basically, just as I said, start them on supportive care, fluids and bisphosphonates. And for triglyceridemia, it's going to be insulin and plasmapheresis. It's not going to be insulin and plasmapheresis, it's going to be insulin plus dextrose or plasmapheresis. If the patient is going into necrosis, you'll have worsening vitals, increasing CRP, no improvement in the ward. And how do you want to treat it? You want to treat it with aggressive hydration and enteral nutrition whenever tolerated. If the patient is going into infected necrosis, that's when you see same worsening vitals, but you will start see IL-6 and procal levels going higher, and the patient will have no improvement. How do you want to treat it? You want to start them on broad spectrum antibiotics, something like meropenem 1 gram every 8 hours for 2 to 4 weeks. And if not improving with antibiotics, you want to do CT guided drainage in the first 2 weeks if you think the patient requires it, or operative pancreatic debridement, operative pancreatic necrosectomy in the next 2 to 4 weeks. Then the difference between pseudocyst and walled-off necrosis. If walled-off necrosis happens after acute necrotizing pancreatitis with fevers and leukocytosis, and pseudocyst happens in patients with after acute pancreatitis with elevated amylase, and I talked about all of those differences and show you a CT as well. In the end, thank you so much for watching this video, and a quote from a beautiful movie called The Wire: "The last few steps are always the hardest." Thank you.